Okay. You've got lots of good info.
That's all I think. I know that not many people do that. Yeah? Is it too loud?
Is that too loud? A little bit too loud.
So what's right? Okay. It's all right? Okay. My name is Raymond Leung, and today I would like to give a talk on preventive oral health in children. I'm a pediatrician, and why I would like to talk on dental care, right? Because it's a really great problem. In 2009, more than 16 million kids has dental problems without care. And more than 50% of the kids between the 6 to 11 has cavities. And but the adolescent, actually 70% of the teenager has dental problems. And the most important thing is that these are preventable. Now, same for the small kids. 30% of them, 30 to 50% of the low-income kids will have early childhood caries. And majority of the problem happen to the 80% of decay happen in 30% of the children. And it is actually much more common than asthma or any chronic illness that happen in children. So the figure that I've told you is it's the national data. So Harvard Midville, Harvard in our area. In 2000, that the Department of Health of Pennsylvania has make a survey and have a report come out, and this is the figure. You can see that, let me see. They don't have a specific number for Midville, but if you look at that, for Pennsylvania, around 50% or 47% have caries at the age of 6 to 8, and half of it is untreated. Compared national is not that, it's actually better a little bit, but for Northwest Pennsylvania, that's different. We are much worse than that of the national as well as the PA. And we have majority of them are not treated. And look at the Pittsburgh, it's not that far away from us, it's quite good. So then, what's the involvement of the AAP? In 2001, the Surgeon General has a report, because it's a big problem, and so called attention on the oral health. And the AAP start to address the problem of the from the pediatric perspective. And in 2003, we have the first policy statement, and saying that we should have a dental home established by the age of 1. And 2005, and then AAP has already, we have a guideline about the physical, what should we check and so on. This is the health supervision guideline, and it's incorporate that into that. And 2008, that is the most recent guideline on the of the policy guideline from the American Academy of Pediatrics. Then you may ask, why the pediatrician? We see all the kids from birth to, in the first year, we see 6 times and 11 times in the first 3 years for the physical or the well-child checkup. So most of the children will see us, but none of them, or let's not say none, but most of them do not see any dentist until the age of 3. And even if they have insurance, even they have the Medicaid insurance, majority of kids will not see any dentist the year before. All right? And even if the dentist here, most of the dentists are general dentists, they may not involve in the preventive counseling. So the counseling, all this service, drop back to the pediatrician or anyone who take care of family practice to take care of the kids. So this is the guideline from the published in Pediatrics in 2008, and my talk is mainly on based on this guideline. All right. Sorry. Okay. So dental caries actually is an infectious disease. It's caused by bacteria, and using the dietary carbohydrate and forming a dental paste, and then the acid is produced and dissolve the enamel and causing cavities. There are many bacteria in our mouth, but only a few can cause the problem. And the most important one is the strep mutans. This is the appearance of the bacteria, but actually there's no difference. All the strep is the same appearance, all right? But it's a strep. Sucrose is the only sugar can be used by the strep mutans to form the pig. But it can use other sugar and digest that and produce acid, and produce lactic acid. And as a result, it dissolve the enamel, right? So sugar actually is not that natural in our diet. It's actually first domestic in around 10,000 years ago in Papua New Guinea. And then it spread to India, and it's around 5,000 AD, and then they say they have a way to concentrate it, but it's just like a herb. It's just like a herb, and it's not that many people can use it. So dental cavity is not that common in the past until they say there's something called slaves, and then they use the plantation, and then we start to have mass production of the sugar. And so that's now why we have all the problems. If you look at all the skulls that's in the past, and we do not see cavities in kids in general. But now, most of the kids have the dental problem. It's because of the sugar. So how do we prevent it? One is that to eliminate, first of all, eliminate the dental flaw is impossible. Always there is some bacteria, but we want to replace the bad bacteria with a good one. The primary prevention is to have the good bacteria in the mom's mouth. And secondly, prevention is to have a good bacteria in the child's mouth. Right? And how to do that? These are the three methods that we use. One is the dietary counseling, and second one is the hygiene instruction and the cleaner teeth and so on. And the third one is the administration of fluoride. So, but before that, we need to assess the risk. Who is going to be at high risk of getting the cavities? And this is a guideline was published by the American Academy of Pediatric Dentistry, and they in 2013 this year, and they have some guideline come out and saying that anyone that the parents have, if the parents have active cavities, if they belong to a lower social economic status, all this will have a high risk, and so on. And if they use fluoride, then there will be a protective effect. And if they, on examination, if they already see cavities, then there will be put them in a high risk as well. This is for anyone who take care of the kids. And they also have something for the dentist. And then this is for still go back. Go back. Let me see. This is still to 5-year-old, and this is for over 6-year-old. But the one that we should use for those who are not dentists will be the one that made by the American Academy of Pediatrics. It's very simple. We just see whether the mom has decayed herself, or they have, on examination, they have cavities. That means if they have cavities, they're more likely to have cavities. They are high risk of developing more. And there are other, if they have Medicaid or they have fluoride, they have protective effect. So whenever you have triangle, yellow triangle, they put them in the high risk right away. But if all this, you just add it together and then to see whether they're high risk or low risk. So how about diet counseling? We recommend breastfeeding for the first 1 year. But it's important to remove the breast from a sleeping infant's mouth. Again, this is common sense. And try to clean the teeth after feeding, before the bedtime. And we discourage baby using a bottle at night before sleep, to sleep with a bottle. And we recommend don't eat that much candy, sugary food, or sugary drink. And we do not recommend juice or pop. And we recommend drink water only, or the milk in between meals. And we also recommend clean the teeth, all right? Brush the teeth and at least twice a day. And if they're at high risk, we recommend the use of fluoride toothpaste. And if they have 2 teeth already touch each other, they should use dental floss. This is a toothbrushing recommendation. This is the pea size of the toothpaste, and this will be probably equivalent to around 0.4 to 0.6 milligram for 3 to 6 year old. And at this age, recommend the daily recommended dose would be this. Right? So this is the size that we recommend. So how do we use fluoride? There's several ways. One is the community, we give fluoride for everyone, and one is that the professional apply the fluoride by the dentist or by the pediatrician. I'll talk about that later. And the use of fluoride used in the toothpaste or the oral fluoride supplement. Now, fluoride Varnish. Fluoride Varnish is a very high concentration of sodium fluoride in an alcoholic-based resin. It's supposed to apply once every 6 months or every 3 months, depending on schedule. And because it's only applied only once every 3 to 6 months, the amount is really small. So there's no chance of getting fluorosis. And it works by increase the very high concentration of local fluoride topically on the tooth. And it stays there for a long time. It can stay up to 7 days once you apply. And it can also remineralize. Even if there's a demineralization, it can remineralize it. And it's especially good for those that already have cavities. So study has been shown that it can decrease the chance of getting caries by 30 to 35%. And it can reverse, as was just mentioned, it can reverse the early decay. And Medicaid actually reimburse the application by non-dental clinician. That means the pediatrician or family practice, whoever take care of the kids. And this is how we do it. And you can see that this is the doctor and this is the parent, and the child lie in this way. And there's a small brush over here and touch the tooth, which is yellow in color. And I have some over here, and if anyone who is interested, you can pass around. And they can open it so that they can see what's inside. I recommend that after that, explain to parents that it can cause discouragement in the first 24 to 48 hours. And they should not drink anything for 30 minutes and avoid any sticky food for that day. The ADA recommend to use it if it's high risk. It can be used every 3 months, but if the low risk, it is not necessary. So as effective as in 2010, Medicaid reimbursed for only under the age of 5, though, all right? Only for under the age of 5, and $18 per application. This is a summary of the article, and so when the pediatrician or the family practice doctor evaluate the child, we assess the risk. If it's low risk, then we recommend to see a dentist around 1 to 1.5. If there's no dental assessment, just like in our area, I don't think any dentist is seeing patients under the age of 3. then we should apply for the fluoride Varnish at a 1 year interval. And if it belongs to high risk, then once the teeth come out, they should send to a dentist. And as far as I say, in our area, majority we have no access to dental home, and then we should apply the fluoride Varnish, give the advice, dental counseling, and so on. All right. So what dental home is a dentist who give counseling as incorporate all the coordinate all the dental care, and it's considered as a one-stop for everything. Now, all I have mentioned, there's some online course, and one is by the Society for Teacher of Family Medicine, and one is from the AAP. And just Google it, all right? Type in AAP, dental health, oral health, and training, you can get this, all right? The note will be like, this is from AAP, and this 11 some hours, 11 hours, all right? So you can go online, and then this is really good. They have some videos, and they are very good, the material. I go through them, and they're very good. And this is from the Smile for Life. If you want to apply the Varnish, you need to, here you can see that the fluoride Varnish, they have some training for that. They have video, and so to do one of the videos, so that you there's some kind of cavities, and then it remineralize after the apply of the fluoride Varnish. So this is good. For pediatrician, we only have 2 hours, but for family practice, because you can see that there's a lot of the adult stuff, and you can get up to 8.5 hours. All right. So, any questions? Any concern? Now, when I make this slide, I do have some concern. For myself, I feel that some problem is there. What is the problem? When we evaluate the risk factor, we found that the only 2 risk factors is very sure to have a very good predictive value. One is that if they have cavities, they're more likely to have cavities. Right? They have cavities. And the second one is that if the parents belong to a lower socioeconomic status, then they're more likely to have cavities. This is the graph you can see. The lower 2 ones belong to, that is the average. But this is a DFS. It means decay and fillings surface. Right? That means it's an evaluation of the teeth, any cavities. Right? The higher the number, the more of the teeth surface is affected. This line is the one that is 100% below the poverty line. All right? And that means represent the poor. Okay. And this is the one is 88 to 94, and in a more recent survey, even more. These are the ones who belong to low social status, and these ones are the average. So you can see that it's significantly more in the poor. All right. Oh, sorry, I get that. Now, this is nothing to do with tea. It's about salt. I've been to some any resident who told me, I've showed this graph to them. We know that sodium is not good for high blood pressure. We recommend them not to take that much salt since the 70s. And we used to recommend, 2.3 grams. All right? So we recommend that. You know what happened? Nothing changed. And then in 2005, the USDA said, oh, it's not good enough. Let us decrease further. For those higher risk groups, more than 50% of that, we will now recommend 1.5 grams. So with that, what happened? Any change? No change. Anyone who take care of patients, we know that change lifestyle is nearly impossible, especially for those who are relatively poor. Remember what I talked about dental health earlier? ask them not to use a bottle, don't use juice. All these require them to